I'm deeply grateful to the organizers for inviting me to come and speak about capacity building strategies effectively employed for child and adolescent mental health in Sub-Saharan Africa. I tell you this morning a story, a child and adolescent mental health story of why we did it, how we did it, and what were the results. Why did we have to build capacity for child and adolescent mental health in Sub-Saharan Africa? Just over a decade ago, there was virtually nothing in existence, very few services, very few trained professionals. And in addition to that, poverty, people living in slums and in very difficult situations. Even up to now, we find that in most sub-Saharan African countries, between 70%, 60% live on less than $1.9 a day. You can see the deep areas. And of course, there's a recurring cycle, a vicious cycle of poverty, lack of education, hunger, low income, lack of potential and opportunity. And of course, the consequence is poor health, physical, mental, and social health. We also have large populations of out-of-school children. You can see Sub-Saharan Africa primary school, millions of children out of school. And of course, we know school is a very important mentally healthy environment. There's a focus on child mortality, high rates of malaria, HIV/AIDS, diarrheal diseases take away the focus from mental health. And of course, there's a neglect. Mental health and physical health are separated, and it should not be that. In addition, the burden increases because we have children in especially difficult circumstances. Street children, working children, children in institutions, and you can see this a juvenile justice institution, lots of children with mental health conditions, children in chains and in pain, children seen to be demon-possessed or witches. Even when mothers come, many times with depression, we have higher rates of depression in the Sub-Saharan Africa. The depression doesn't manifest as depressed mood or loss of interest, but in their children as frequent malaria, neurodevelopmental concerns. 1 in 5 would have a mental health condition. And of course, 50% of adult psychiatric illness starts before the age of 14. What was the state of calm about over a decade ago? Few camp services, shortage, lack of training opportunities, no mental health in child health services. So that was why we embarked on this capacity building story. And that's the story I tell you. How did we do it? We felt we needed to have an 18-month training Masters of Science program in the College of Medicine, University of Ibadan. And what were the 5 ingredients we needed for this? The first important, funding. We're so grateful to the MacArthur Foundation for providing us with the seed money that we started off with. Funding is key to so many things. We also needed services and facilities to train. Fortunately, I had been involved in developing services. I initiated the first mental health clinic for children and adolescents in my hospital and built this up through training. It expanded. We also needed trainers. There were virtually no trainers on the African continent in Sub-Saharan Africa. So we built partnerships on the International Association for Child and Adolescent Psychiatrists, and all through collaborations with Harvard Medical School, Imperial College, and particularly I must emphasize that we had Africans in the diaspora who came to help us in the initial period. And as we built local capacity, they were less able to come. We did not need them so much anymore. Trainees also. We needed scholarships, which we got from the funding. We used networks to attract trainees into our program. And of course, curriculum was very, very key. And I give you 5 ingredients, 5 essential aspects of the curriculum. First of all, practical clinical sessions to change attitudes were very, very important. Collaborative methods with parents. Leadership was very important because these were pioneers going back to their countries. Multi-professional training. It was not limited to psychiatrists or psychologists, but we brought in different people. And of course, research was very, very important. You build research, and that leads to policy. And then we use free online resources, the IACAPAP textbook and the MHGAP, a WHO package. And then I give you very quickly 10 outcomes of this capacity building story. The first is that we had, in just 10 years, 124 trained, and of course, more females than males. These are the sets we turned out year by year. Year by year, we were turning out, and then from 14 Sub-Saharan African countries we were able to train. Cameroon, Eritrea, Nigeria, Ghana, Liberia, Sierra Leone, Rwanda. And so we were building up capacity for mental health, child and adolescent mental health on the African continent. That's the advocacy has started in all these countries. And our graduates have pioneered services all over the African continent. Multidisciplinary training, sustainability. Those who are running the program now are graduates of the program. Research, we've been able to produce 23 peer-reviewed publications, and these are still ongoing. And then attitudes have changed. Many of those who came now know that mental disorders are manageable very effectively. NGOs are formed across the African continent. And then the 10th component is leadership. Many of our graduates are now leaders. We have Simbogani Kayola, country director for Massey Course. We have a leadership here from Cameroon, a youth commissioner in Lancet Commission for Child and Adolescent Wellbeing. And then the African Association for Child and Adolescent Mental Health is led entirely by our graduates, the president, vice president, the secretary, leading child and adolescent mental health services, facilities, advocacy, policy on the African continent. That's the precedent. And with that, I end my story of why, how, and what with regards to capacity building for child and adolescent mental health in Sub-Saharan Africa. I thank you for listening.